Lovely to be with you this morning, and thank you very much, Mark, for the invitation and the opportunity to present. Are we up with our... Thank you. So this morning I just want to take you on a wee bit of a journey from where we've come from around HIV in New Zealand and where we're going. So I want to start by 1981. Who was not alive in 1981? Okay, so there's a few. So just to refresh your memories, and for those of you who weren't alive, and just to give you a bit of what was going on in 1981, Ronald Reagan became the 40th President of the United States. Bob Marley, I think in May of 1981, passed away. And of course, the big event, Charles and Diana, who could forget? Those of you who are musos, Rolling Stones, the young Rolling Stones, their tour of America, and Olivia Newton-John, Let's Get Physical. And Superman was the top box office movie. And of course, here in New Zealand, we had the Springbok tour and the demonstrations around that. So a lot going on in 1981. For me personally, I was a brand new graduate nurse starting in Palmerston North Hospital, terrified of being a new graduate nurse. But meanwhile, in the US, there were these new cases of pneumocystis carinii and Kaposi sarcoma being reported by the CDC. And they were cases found in young gay men, so very unusual what was going on. A lot of you will know all of this, but I think it is good just to go back and think about what was going on in that time. So that was 1981, 1982. There was then evidence that this was the sexually transmitted agent that might be implicated in this. 1982, there were reports of the disease in immigrants from Haiti and also in haemophiliacs. In August, the condition called AIDS was actually defined, and also at that time it was noted in a child who had received blood transfusions. Then it wasn't until another year later that the virus was actually identified in Paris, in a laboratory in Paris. And then not till 2 years later, in 1985, that there was the commercial antibody test for HIV. Screening for donated blood was initiated. There was a lot of stigmatization because all of this was really unknown, what was going on. And that was the first time that President Reagan actually mentioned AIDS. So, that was a whole journey of 2 years up to that. When you think in the context of what we've had recently with COVID and the speed at which everything happened, and the acknowledgement by world leaders and so forth that, this, and the speed of the vaccine, all sorts of things, and then the time that it took for this to evolve with HIV. These Time magazine covers also give some kind of idea of what was going on over the years. July 83, I'm not sure how clear that is. The AIDS hysteria. February 1987, just as examples, how heterosexuals are coping with AIDS. And then 1996, Dr. David Ho, the person with the antiretroviral therapy who developed that. And then, of course, in the early 2000s, the escalation of the epidemic into the African continent. So, a huge timeline, and of course globally since that day, we've had 84 million people have been infected with HIV. They're massive numbers. 40 million people have died, and as at the end of 22, 39 million people estimated to be living with HIV. And these are numbers, you can look them up on the UNAIDS website. And then just in 2022 on its own, 1.3 million new infections and 630 deaths due to AIDS. So massive numbers. This is also from UNAIDS, the number of new infections globally up until 2021. So you can see that the numbers are going down. And UNAIDS have these targets, and by 2025 they want less than 370,000 new infections, and then by 2030 they want less than 200. I haven't put the line there, but I think if you draw a line from just keep tracking down, I think we're going to overshoot that 25 and 2030. So in the meantime, back here in New Zealand, I've put on this slide and just shown just some of the things that have been happening over those years for prevention and control. And, I really do want to stress that these are just some. There's a whole lot of things at all different levels. And I think what needs to be really emphasised, that much of the prevention and control has been initiated by people living with HIV and people most affected, the groups most affected by HIV. Enormous impetus and for change and for establishment of homosexual law reform, needle exchange program, decriminalisation of sex work, opt-out of antenatal screening. I'll come back to some of these things as I go along, but really just to emphasise there's been just massive input from the sector and from the stakeholders particularly to get to where we are now. So this is the numbers, and this is what we have normally on our AIDS New Zealand newsletter. So I think I'll move on to describing these in more detail, but at a glance you can see that the red line at the bottom, that it's been mostly amongst MSM, men who have sex with men, apart from in those early 2000s where there were a lot of heterosexual men and women. And then more latterly, the sort of very light grey bars at the top are people who have been diagnosed previously, first overseas and now coming to live in New Zealand, or New Zealanders coming back to live in New Zealand. And from this you can see that the peak in notifications was in 2016, and since then it's been fairly much declining except for 2022, which was up again. So this slide just looks at the people who are diagnosed in New Zealand. And again, you can see that throughout the epidemic, it's been predominantly men who have sex with men affected, and at that peak in 2016 with quite a dramatic drop since then, and I'll explain that. Amongst heterosexual men and women, which is the blue line, that peak in the early 2000s, which was mostly people coming from African countries, and then there was the immigration legislation in 2005, and that stopped some of that. And then heterosexual men and women numbers have been fairly constantly and fairly low over the last 10 or so years. And then amongst people who inject drugs and mother-child transmission, tiny, tiny numbers along the bottom. So just looking at men who have sex with men. So this is then breaking it down. This is what we do. We look at the big picture, then break it down by diagnosed in New Zealand, and then looking at place of acquisition. So the black line at the top is reported to have been acquired in New Zealand. And so again, we can see that major drop since 2016 in MSM who acquire HIV in New Zealand. So most likely that drop has been due to these this combination prevention. So the removal of the threshold for ART, so U equals U, undetectable equals untransmissible. The introduction of PrEP, subsidised PrEP, and the availability of that, and of course the ongoing Burnett Foundation and other stakeholder groups testing promotion campaigns, this one that they had, everything's changed. Stay safe, test often, treat early, ending HIV. And of course, the impact of COVID-19 in 2020 and 2021. So we are just watching to see what will happen as we go forward. But most likely that decline has been due to those different factors. And the decline that we've seen so far in MSM has mostly been in European MSM, which is the blue line at the top, and then mostly MSM living in the northern region, which is the blue line at the top on this one on the right. And then if we look at the CD4 count, which is at the time of diagnosis, and that gives an indication of whether somebody is relatively recently acquired HIV or whether it might have been an infection some months or years ago. And so that green line, it's a wee bit messy, but the green line at the top is a high CD4 count, so relatively newly acquired HIV cases. And so that decline over the years since 2016 has been mostly in that group. If we look at men and women with heterosexually acquired HIV, again, I'm just going to put this in. So this is by place of acquisition, and that red line at the top, that peak in the early 2000s, and then the introduction of the 2005 immigration policy with HIV testing requirements. This has now changed again, and that testing, still the testing requirement, but there's still that the immigration policy has changed in 2021, so we will just be watching these numbers to see what happens as we go forward. So very low numbers of heterosexual men and women, and that also gives you the breakdown by men in the blue bar and women in the orange. So over those years from 2010, an average of 5 men and an average of 7 women per year. Amongst heterosexual men, it's predominantly European men, which is the 67%. Amongst heterosexual women, it's around half who are European, 20% Māori, and equal proportions of African, Pacifica, and Asian women. So that's a percentage. Remember, these are very low numbers that are reported diagnosed each year. And then, again, just coming back to that importance of having really good prevention and control, just that foresight of starting that needle exchange program back in the 1980s, just a major impact on keeping these numbers of people who inject drugs acquiring HIV very, very low in New Zealand. So this is the blue bar at the bottom. So really, only the peak year was in 2021, which was 6 cases. So major shout out to the people in the needle exchange program for the work that they do, and also to the people who back there in 1987 had the foresight to get that established. And then this is the number of children diagnosed with mother-to-child transmission in New Zealand by year of birth. And again, I've put in the year that the opt-out antenatal HIV screening program started. And so since 2007, there's been no child born in New Zealand with perinatally acquired HIV. And that's just a real celebration. I always say this with some hesitation because, we need to be vigilant with this. And it's a huge success. It's, again, a huge shout out to the people who set that screening program up. And that's just been hugely effective, and we just need to keep being vigilant with that. And then just looking at the number of AIDS diagnoses and deaths. And of course it was in 1986, the Time magazine cover, 1986, that advent of antiretroviral therapy. And so since then, huge impact on the number of people being diagnosed with AIDS and the number of people dying with an AIDS-related death. Still, in 2022, we are seeing some cases of AIDS, and I will come back to that because we want to see that at 0. So just to summarise where we've come from, and again, really I want to re-emphasise the amazing work by many in the sector who have been working over the years and continue to do so. That I think, we've really seen the effect of that in these numbers. So the decline in recent years of people being diagnosed in New Zealand, decline in those acquired in New Zealand, mostly European MSM, and those very low numbers of men and women heterosexually acquiring HIV, people who inject drugs, mother-to-child transmission. And as I mentioned in the first slide, there's been an increase in people first diagnosed overseas, and that's changing as we go forward. There's something to watch. So where are we going? I think I'm still on track, time-wise. Yep. So most of you will be aware that we now have this National HIV Action Plan for 2023 to 2030, released earlier this year, with this vision of an Aotearoa New Zealand where HIV transmission is eliminated and all people living with HIV have healthy lives free from stigma and discrimination. And underneath that vision are these 5 goals. So this morning I just really want to address goal number 1 and a little bit about goal number 3. So, where are we going? So under goal number 1, it's reduced number of new locally acquired HIV infections, with the target for 2030 to meet the UNAIDS target, which is a 90% reduction of locally acquired infections compared with the 2010 baseline. And I will also talk about the other 2 goals below that. So this is, as I showed you before, for MSM, and this is the blue line up until 2022, shows that peak in 2016, and then the subsequent decline. The line carrying on from 2022 with the little markers on those things going up. It's the confidence interval around the projected numbers that we've done this, what's called a Poisson regression model with these confidence intervals around it. And we've based that on the observed cases from the peak in 2016 to 2022. So the 90% target means we need to have 7 MSM in 2030. So from our projections, the quickest, as soon as it gets to that, actually I'll use this, is 2028, where it meets that bottom marker of the lowest point of that confidence interval in 2028. If we look at the projections for the total, so this is heterosexual men and women as well as MSM, so the projection that what we need to get to is 9 cases. And this is again that same idea of taking from the numbers from 2016 to 2022 and then modelling that going forward. And the soonest we would see that is in 2031, so we're not going to get there by 2030. So just some points to note about this, that all these are models, and they're just based on what's happened between 2016 and 2022. And so it's assuming that same rate of decline, which is fairly unrealistic. there's always going to be, and especially when we get down to really small numbers, there's always going to be a lot more fluctuation in numbers. And it might just be, one particular case that has a lot of unprotected sex with someone else, and, in 1 year we could see a peak. So it's always going to be some fluctuation. And it's also assuming that there's no changes in the diagnostic or treatment or preventive actions. So we're just assuming status quo. So, we've now got this amazing action plan, and we're, those prevention measures might be amped up quite considerably in the next years. So this is a model. It's not saying this is exactly what's going to happen, but this is our best guess. So the challenge really is, how to reach, we can probably meet it with MSM, but how to reach those populations outside of the main MSM European population group while maintaining the emphasis still on MSM and Europeans. We can't forget those people, but to also reach people who are outside of those mainstream groups. Of course, the race is on to be the first country to reach elimination. I've just shown you a couple of slides here. This is Australia numbers on your left and England on your right. And the headline, Sydney almost eliminates HIV transmission in global first. I might add that that is a group of MSM in inner Sydney, so they might reach elimination in that group, but there's still a lot of work to be done in Australia with the other groups of people. Both in England and the UK, Australia and the UK, the numbers are tracking down, but yeah, I thought just put that up just so that you can see how we might be doing. But, New Zealand could potentially be the first country to reach elimination. It's going to be hard because the numbers are getting very small and it gets more difficult. I just want to come back to people who inject drugs, and so the target for that is to sustain that low incidence of HIV among people who inject drugs. I would say that's absolutely possible. There's a target amongst sex workers to sustain the low incidence of HIV among sex workers. For those years 2010 to 2022, there have been 12 on our record who had contact with a sex worker or amongst sex workers, so it's absolutely possible to maintain that low incidence. And of course the target for 2030 for mother-to-child transmission is to maintain 0 cases of mother-to-child transmission, and that's also absolutely possible. So just a couple of slides on goal number 3, the decreased mortality and negative consequences of HIV on health and well-being. So the targets for 2030 with this is what we call 95-95-95. People knowing their status, being diagnosed and on treatment, and having viral suppression. And the fourth one, no AIDS-related deaths. So from some of the work that we've done, this is just looking at those diagnosed or notified with HIV between the first one, 26 to 2020, who are on treatment, and then the lighter sort of orange, lighter bar is with viral load suppression. And the green line at the top is the 95% target. So these are cross-sectional analyses of people notified with HIV in those years 2006 to 2020, and then the middle one, 2006, with one extra year added to 21. And that's through cross-linkage of data. And then the third one is looking at post-diagnosis forms that we ask clinicians to complete, and that's just for 1 year of people notified in 2022. So it looks like we are on target, but this will likely be an overestimation because we can only do data linkage on people we have in our database since 2006. But it's looking promising. And then the other target around no AIDS-related deaths. And again, we can see that that's very much gone down, and it's absolutely possible to see that target met. So just to conclude, remind you again of the vision. So I think New Zealand is in a strong position to eliminate HIV transmission, but we will have to, while still keeping a focus on MSM because they are the main group affected by HIV, but it will be necessary to reach out to those other groups who are not necessarily engaged with the key groups, who might be living in more remote areas, who might be just not engaged with MSM community, or really to reach out and find those people. And that's going to require a lot of extra work. We're going to have to think smart, culturally relevant, thinking about cost effectiveness, and tailored for different groups. And two things I want to say, UNAIDS have this slogan of leaving no one behind, and that's going to be really important. It's going to be hard because the numbers are getting down to, we're in this unique position in New Zealand that we had small numbers at the beginning, so getting down to reaching elimination is going to be very, very small numbers, and it's going to be hard, and it's going to require major challenges ahead. And overarching all that, and I've highlighted it in the red at the top, having healthy lives free from stigma and discrimination. So stigma and discrimination still surrounds all of the aspects of HIV, and that's really important to appreciate that and to deal with that as well. So just want to finish by acknowledging the organisers and sponsors of today's meeting. Thank you. And all the clinicians, clinical nurse specialists, support staff, laboratory staff who always provide us with amazing data and put up with us asking them questions all the time and going back to them. And also thanks to the Ministry of Health for our ongoing funding. If you want to look at our data or any of our information, we do have a website, and we also now have a dashboard, so you can have a look at the numbers, and please give us any feedback you have on that dashboard, or get back to us if you want any further numbers. Thank you.